Okay, now extra or gallop sounds. Extra or gallop sounds. In extra or gallop sounds, S3 is heard just after S2. So S1, S2, S3. S3 is heard just after S2. It is caused by reverberation, reverberant sound as blood fills an enlarged left ventricular cavity. As blood fills an enlarged left ventricular cavity during diastolic filling. So it is caused by reverberant sound as blood fills an enlarged left ventricular cavity during diastolic filling. What are the cause? Heart failure with reduced ejection fraction, high output state like hydrotoxicosis, and MR and AR. These three is a very high end cause for S3. So look at this video. So in here, S1, which is mitral and tricuspid valve closure, S2, aortic and pulmonary valve closure, and then S3. So reverberation of enlarged left ventricle at the end of the passive filling. Reverberation of the enlarged ventricle at the end of passive filling. So what are the causes? Causes are heart failure with reduced ejection fraction, AR and MR, and high output states like hydrotoxicosis. And the S4 heart just before S1. It is caused by blood striking a stiff left ventricle, blood striking a stiff left ventricle during atrial contraction, blood striking a stiff left ventricle during atrial contraction. Causes are concentric left ventricular hypertrophy, acute MI, concentric left ventricular hypertrophy, acute MI, and restrictive cardiomyopathy. These are the S4 sound. S1 mitral and tricuspid valve closure. S2 aortic and pulmonary valve closure. Sound of blood hitting stiffened left ventricle. Okay, so these two S4 S4 is concentric left ventricular hypertrophy. In here there may be chronic hypertension. Concentric left ventricular hypertrophy has multiple causes. Uh, Acute MI and restrictive cardiomyopathy. Okay, this is the aortic regurgitation. Aortic regurgitation has two types of marker actually. Root dilatation marker, which is root dilatation, aortic root dilatation happens in Marfan syndrome. It, the area is aortic area, and the actual air which is in the left, mm, which is in the third intercostal space, left mid sternal area. So this is the aortic regurgitation. In aortic regurgitation, what type of murmur we can found? In aortic regurgitation, AR, early diastolic murmur can be found. So diastolic decreasing. So this is a R murmur, diastolic decrescendo murmur, mitral valve prolapse, late systolic murmur, MVP or mid systolic click may be found best heard at the cardiac apex, mitral valve prolapse. This is the click. It's a late systolic murmur. That one is the left systolic click, mitral valve prolapse. Okay, now pericardial effusion. In here we know the friction rub will be found. This is the sound of the friction rub. Hmm, okay, this is triphasic murmur, louder at left sternal border. Triphasic murmur, louder at the left sternal border while leaning forward. Triphasic murmur, louder at the left sternal border while leaning forward. This is pericardial friction rub. That's it. Okay, okay. After murmur, I would like to discuss about the some causes of the shock. In this question, there is a very high thought is present, like mixed venous oxygen consumption. Mixed venous oxygen saturation is 82%. Mixed venous oxygen saturation is 82%, normally 60 to 80, and it is high in one condition like distributive shock. So mixed venous oxygen consumption, and cardiac index. Mixed venous oxygen consumption and the cardiac index both are high in distributive shock or septic shock. So the distributive shock are divided into again sepsis and anaphylaxis. So these two are mm, high in distributive shock. So in case of hypovolemic shock, right-sided preload, central venous pressure, left-sided preload, pulmonary capillary wedge pressure is low, cardiac output is left ventricular output or cardiac index is low, systemic vascular resistance is high, and mixed venous oxygen saturation, that means SVO2 is low. Mixed venous oxygen saturation is low. So in hypovolemic shock, right sided preload low, left sided preload low, cardiac index low, SVR high, systemic vascular resistance is high, and mixed venous oxygen saturation mixed venous oxygen saturation SVO2. Mixed venous oxygen saturation is low. In cardiogenic shock, from right side preload is high, left side preload is high, cardiac index is low, systemic vascular resistance is high, and mixed venous oxygen saturation is low. Mixed venous oxygen saturation is low. In obstructive shock, tension pneumothorax, pericardial tamponade, these are the obstructive shock. In obstructive shock, uh, mm, Right-sided preload is high. Intention pneumothorax right-sided preload is high. In mm, pulmonary capillary wedge pressure or left-sided preload is low. The left-sided preload is low. In tamponade, the left-sided preload is decreased because measured pulmonary capillary wedge pressure is paradoxically increased due to external compression by the pericardial fluid. In tamponade, left-sided preload is decreased, but measured pulmonary capillary wedge pressure is paradoxically increased due to external compression by the pericardial fluid. Actually, left-sided preload is low, but if measured pulmonary capillary wedge pressure is paradoxically increased. In cardiac index, what happens in the cardiac index? It is low, systemic vascular resistance is high, SpO2. That means mixed venous oxygen consumption is low. Now the distributive or anaphylactic shock. In distributive shock, everything is low. Everything is low. Cardiac index is high. Mixed venous oxygen consumption is high. Mixed venous oxygen consumption is aortic dissection. Aortic dissection is a very high health topic. Aortic dissection has multiple causes: chronic hypertension, cocaine, and morphine. Aortic aortic dissection. Oh, sorry, chronic hypertension, cocaine, and morphine and Marfan syndrome. Okay, so in here, CT angiography and transthoracic echo for definitive diagnosis. If the patient is hemodynamically stable, go for CT angiogram. If the hemodynamically unstable, go for esophageal echo. In here, there is what happens. This patient has acute onset central chest, acute onset central chest and or epigastric pain, acute onset central chest or epigastric pain, or radiating to the mild lower back. The pain started an hour ago while he was lying on the couch. The patient drinks 3 to 4 beers, hypertension, tachycardia, tachypnea, BMI is 34, left brachial pulse is diminished than the right. So in these point, like BP abnormality, variation in the systolic blood pressure between two arms, variation in the systolic blood pressure between two arms is a very high level. If variation in the systolic blood pressure is different, ECG shows tachycardia, data MR elevated, looks like dissection, and in dissection CT aortography should be done. There may be multiple. The diagnosis confirmed by the CT angiography of the aorta. CT angiography of the aorta, also known as CT aortography. CT angiography of the aorta, also known as CT aortography, showing intimal flap and double aortic lumen. Intimal flap and double aortic lumen. This patient has again dissection. In here, the patient is very hypotensive, and CT aortography or CT angiography of the aorta is not present. CT pulmonary angiography, CTPA for pulmonary embolism, but transthoracic echocardiography for aortic dissection. This patient has chest pain, syncope, dyspnea, hypertension, JBP elevated, low voltage QRS bedside. Done. Go for aortic dissection. So suspected aortic dissection. Abrupt onset severe chest pain, back pain, widened mediastinum, chest X-ray, anti-impulse therapy to reduce aortic wall stress. To reduce aortic wall stress, IV beta blocker, pain control, and with morphine. Confirmatory imaging is CT Angiography of the aorta, all CT aortography type A, surgery type B. So these question, premature atrial complexes on ECG. Premature atrial complexes, back. Premature atrial complexes or atrial premature beat. These are the premature atrial complexes. These are the premature atrial complexes. Different shapes of ethanol, different shape from SA node generated P wave, different SA node generated different, so different shapes P. Mm, irregular rhythm, PAC, premature atrial contraction. Okay, so in PAC, I advise him to limit tobacco or alcohol use. Also, we need to go for the precipitating risk. If there is chronic venous ulcer, chronic venous insufficiency, chronic venous insufficiency, maybe advanced age, family history, prolonged standing obesity, prior DVT, leg elevation when possible, leg exercise, ankle flexion, and walking to increase the calf strength, leg exercise to increase calf strength and venous return, compression therapy, dilated superficial vein, this is telangiectasia, dilated small dermal vessel, dilated small dermal vessels. This is varicose vein, hyperpigment skin, varicose vein, skin discoloration in more cases, skin discoloration. This is stasis dermatitis, lipodermatosclerosis. Lipodermatosclerosis is proximal accumulation of the fluid. This one, lipodermatosclerosis, champagne bottle inverted, champagne bottle appearance inverted, champagne bottle appearance, soft tissue fibrosis causing constriction, soft tissue fibrosis causing constriction. This is a venous insufficiency ulcer. This one is venous insufficiency ulcer. This is the JBP estimation normal. This is the central venous pressure estimation, CVP estimation, JVP plus depth of the right atrium. Central venous pressure CVP, so CVP equal to JVP plus the depth of the right atrium. Normal central venous pressure, it is normal central venous pressure is 6 to 8. Elevated CVP. Yeah, patient should be kept into the 30 to 45 degree. Depth of the right atrium is 5 centimeter. Depth of the right atrium is 5. Depth of the right atrium is 5 centimeter. Then JVP should be measured. Normal JVP is 1 to 3. If it is more than 3, that is elevated JVP 5 plus more than 8. 5 plus 3 equal to 8. So more than 8 is elevated central venous pressure. Elevated central venous pressure. Elevated central venous pressure. That's it. So this question, how to diagnose this question? This patient is cyanosis. So all the cyanotic heart disease, all the T's should be coming for tetralogy of fluid, transposition of the great vessel, total anomalous pulmonary tricuspid. So all the options should be excluded. And oxygen administration by Hood is not improving his cyanosis. Looks like transposition of the gut vessel cyanosis within 24 hours of life. Single S2. This one is very high. Single allowed S2 on auscultation. Single allowed S2 absent pulmonary component. because of the aorta is anterior to the because of the aorta is anterior to the pulmonary artery, single stenocecal region, and this is transposition of the great vessel. Gestation arrhythmia egg on string appearance, egg on string appearance. Abdominal aortic aneurysm can be caused by active smoking. Management of abdominal aortic aneurysm, ultrasound, lifestyle modification. Arrhythmia. Arrhythmia. This is the cardiac syncope. Syncope has multiple was a reflex syncope, orthostatic syncope, and cardiac syncope. And if inferior MI right RCN fraction, at that time you need to give hydration, but it is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy have dynamic left ventricular outflow tract obstruction. The degree of the left ventricular outflow, it is worsened. What is worsened? Um, this is hypertrophic cardiomyopathy. Look at the
Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is characterized by enlargement of the interventricular septum. The enlarged septum restricts flow through the left ventricular outflow tract. Outflow obstruction varies with left ventricular volume. Standing causes blood to pool in the legs and reduces venous return to the heart. Left ventricular volume is decreased, which worsens the obstruction and accentuates the murmur. In severe cases, systolic anterior motion of the mitral valve leaflets may further exacerbate the outflow tract obstruction. Other maneuvers that decrease left ventricular volume, such as Valsalva strain phase, will also accentuate the murmur. Squatting increases afterload by compressing the vasculature and causes the pooled blood in the legs to mobilize. There is an increase in venous return to the heart. Left ventricular volume is increased, which lessens the obstruction and decreases the murmur. Supine leg raise and hand grip also increase left ventricular volume and decrease the murmur.
Okay, what are the maneuvers increases the murmur? These maneuvers like standing and Valsalva phase actually increases the murmur. Standing, Valsalva sprint raise, decrease left ventricular volume, increases obstruction. But squatting, supine leg raise and hand grip SASP decreases the murmur. SSP decreases the murmur. Okay, that's it. That's all. Okay, there is a one question I would like to discuss about that coronary thrombosis. If you mm, put an stent, the patient has resident unstable angina, intermittent chest pressure for 12 hours, ST segment elevation in the LAD artery, ST segment elevated MI, most likely coronary artery, coronary stent thrombosis. Okay, there are two types of stent, bare metal stent and drug-eluting stent. Drug-eluting stent, longer thrombotic risk period, longer thrombotic risk period, late endothelialization, longer thrombotic risk period, longer thrombotic risk period, late endothelialization, and lower risk of recurrence, and lower risk of recurrence. Drug-eluting stent, bare metal stent, shorter thrombotic risk period, early endothelialization, shorter thrombotic risk factor, early endothelialization, higher risk for stenosis. So bare metal has higher risk of stenosis, early endothelialization, shorter thrombotic risk, but drug has longer thrombotic risk, lower risk of restenosis. That's all. That is all about the today's discussion. regarding murmur, shock, aortic dissection, and coronary stent thrombosis. Hope you enjoyed.